Well, hello. We still have a good handful of people trickling in. Thanks for anyone that's been waiting. We had a little technical difficulty, but we've got it figured out. We'll make it work. All right. Well, thank you all who have joined on this, what is here in Eastern North Carolina, a very hot and steamy summer evening. And thank you, Dr. Brady, for offering your time to come talk to us tonight. For those that are joining our talk for the first time, what we will do is we'll send out your CE certificates in the next week and a half to your email address that you use to register. And if you have any questions tonight, go ahead and put them into the chat. And I will either interrupt Dr. Brady, depending on what the question is, or if it's something that I feel like can wait till the end, we'll have a Q&A session at the end. And but yeah, everybody is muted. And I am very happy to have Dr. Robert join us tonight, Dr. Robert Brady, for It's Not Always Fun, but we got to get it done, a refresher on canine neurological examination and localization.
All right, thank you, Paige, and thanks everyone for coming in this evening. This talk is going to be naturally a little bit geared towards surgical disease, and may vary slightly from a true neurologist's perspective, but overall, hopefully a helpful bit of information. So, main slide. So about me, in case you guys didn't know. I'm local. I went to East Carolina, got my undergraduate degree in kinesiology, followed by a master's in biomechanics, then went over to St. George's for 3 years for academic training, and then I didn't put it up there, but I went to UT Knoxville for my clinical year, 1 year rotating internship in Charlotte, 3-year surgery residency at Memphis Veterinary Specialist. Started at Points East in September of 2020, and now I'm a diplomat of the American College of Veterinary Surgeons, -SA for small animal. So I don't really know much about the large animals. A little bit more about me personally. My family picture, that's my wife Abigail, who also works at Points East. Our 2 youngins, the little one is Emerson, the big one is Deacon. We have a 3rd youngin on the way, due August, so pray for Abigail over the next couple of months as she gets through this hot summer. And then we have a little hobby farm that we lovingly call Swamp Dog Farm. We have goats and chickens and whatnot. So as we get going, we'll start off with some questions to begin with. And first and foremost, just to kind of see what kind of crowd we're dealing with. We're curious who enjoys a good neurologic workup. So we'll get that poll going now. Feel free to put your votes in. Shouldn't take too long, and then we'll see how many of you guys enjoy a good neuro workup. All right. Oh, I can't believe it. 100%, 50-50 of you guys. 50% of you said yes, 50% said not me. So I'll have a bit of a diverse crowd through this. So that's really a good start. So now the next question for you guys is, which of you following is the most common lesion localization that you encounter? Or most of you guys seeing brain lesions, C1 to C5, C6, T2, T3, L3, L4 to S1. Some people say S2, some people say S3. Doesn't really matter for all intents and purposes, but in practice, get a feel for what you guys are dealing with. You feel mostly in your hospitals. All right, so we got the vast majority T3, L3, which is what I was expecting, and mostly what this talk will help with. Second, we have brain, then some L4, S1, and surprisingly, nobody had any C1 to C5 lesions. So that's a little bit interesting, but nonetheless. And then the big kicker here, everybody be honest. How many of you actually remembered those lesion localizations before seeing them on the screen just now? And it's okay. It's okay if you don't remember that all, but hopefully after this talk this evening, it'll be a nice refresher for if you maybe let some of that old neuro stuff slip. All right. Well, once again, very much a 50-50 split. Congratulations to all of you that remembered that little detail from neuroanatomy. The rest of you, that's okay too, as long as you can have an idea of where you think the disease is happening, and hopefully a little bit stronger after this talk this evening. So ultimately, as with so many things in life, we would get through vet school and we're thinking, man, I'm not going to need to know this. I'm not going to need to know this. And then we got in the real world and we're like, man, I wish I had remembered that. And neurolocalization is something that probably comes back to most of us from time to time. Remember, we have our first lesion, the brain, then we have C1 to C5, C6, T2, T3, L3, L4 to S1, 2, or 3, depending on which textbook you're reading. And then we have a whole lot of other categories that we're not really going to delve into this evening, like lower diffuse neuropathies, polyradicular neuropathies, et cetera, et cetera. So we had t-shirts in our first year anatomy class made with a picture similar to this. And one of the guys, Gurdeep, he wore it to our exam, and the teacher called on and they made him turn his shirt inside out. It was kind of funny, and made a lot of sense. So when we start our neurologic exam, it's best done before the administration of any pain medications, especially opioids or other dissociatives. We don't want to really alter that mental status of the pet before we have a chance to do our exam, which I know sometimes can be difficult, especially if you do have an acutely down dog that's very painful. It's really important to try to get that neurologic assessment, especially the cranial nerve and brain component, done before giving any, mentally altering drugs. But at the same time, we have to be very safe with what we're doing. So you have to weigh the pros and the cons and the risk of that. But anytime you're going to do a neurologic exam, it is best to have that patient as neurologically centrally sound as possible. For repeat neurologic exams, these are typically saved for when it's about time for another dose of opioids, or if they're on a CRI, discontinuing that for 10 to 15 minutes, depending on the drug, of course, to allow those effects to get out of their system so we can do a good, accurate neurologic exam without mental drug-induced considerations. So going all the way back, again, one of those things that maybe we remember, maybe we don't, the cranial nerves. Cranial nerves, we're just going to touch on this again. We're going to work mostly on peripheral disease throughout this talk, but a couple of the mnemonics that I learned in school, and then again for boards: on old Olympus, towering tops, a fat-vested German viewed all hills. There's some other variations out there, but that's the one I chose to put on the screen. The list of the 12 cranial nerves, again, more of a reference for you guys if you like to have that. And then the other thing about the cranial nerves is remembering, are they sensory, are they motor, or are they both? So the cranial nerve responsible for relaying sensory only information, is it responsible for motor only, or does it have both categories? And that's where the mnemonic on the bottom comes in handy, where some say marry money, but my brother says big brains matter most. And then of course a little diagram there in case you're ever question on Jeopardy of which one of these nerves comes from there. You'll have a quick reference. And the dog brain is remarkably similar to the human brain in terms of these locations, which is pretty cool. A lot of other differences, but we'll not delve into that. For the cranial nerves, the first and foremost thing is the patient's sensorium. So is this patient just, does it seem normal? Is this animal come in as a normal dog, or are they obviously dull or obtunded or even comatose, or are they just not right? Vision is another huge component of the cranial nerves. That's pretty easy to tell if a dog can see or not. If you have any questions, setting up a little obstacle course, or just seeing if they follow you around the room is significant. A lot of dogs with cranial nerve or brain disease will have some amount of circling, especially for those forebrain lesions. Most often, those lesions are associated with the side that they're circling. So they're circling to the right. Their lesion is typically on the right. But there is an interesting disease process called paradoxic vestibular disease, where they'll have the head tilt, for example, on the left, they'll be circling to the left. But when you do their CP deficits, the proprioceptive positioning, their defects actually on the right. That's called paradoxic vestibular disease. So the lesion in that case is actually on the right. So just something to be aware of if everything doesn't quite add up as you'd expect. And again, remembering those cranial nerves, are they sensory, motor, or both? So neurologic cranial exam, again, pretty abbreviated for tonight's discussion. And in general, unless you suspect there is cranial nerve dysfunction or head trauma, can be done very rapidly. And so especially, again, if you're not thinking there's any neurologic dysfunction associated with the brain, just a simple 1 minute long kind of feel over them, more or less. For example, does the animal track you or an object? Are they following you around? Are they moving their eyes? Is there a head tilt? Do they have palpebral? That's a pretty simple walk in the room, see if they follow you, make sure their head is straight up and down, their eyes are moving as they should. Give them a little pat on the face, see if they blink. If you have some treats handy, that's very helpful. Do they sniff? Does it seem like they can smell? A bonus if they'll eat it. They'll eat a little treat for you. It may not always in the hospital, but that gives you a lot of information there. So in the parentheses beside each of these is the cranial nerves that you're actually looking at. And in the corner, there's also a reference again to those 12 cranial nerves. Are they annoyed if you tickle the inside of their nose? Have a little hemostat or a pin or something sticking in their nose, so they react. Or around the muzzle, in the ear, those types of things allow us to really focus in on where a lesion may be, especially if we're super thinking there is a cranial lesion. Do their pupils respond appropriately to light? Simply, do you walk in, are their pupils very myotic or mydriatic, very small or very large? Are they both symmetric? And then in non-cranial disease pets, again, this can be done in about a minute. Just a little walk around the pet, a little pat, little touch here, touch there, and you have a very good sense of is there any cranial nerve disease. So glad the brain part is over, because that's a 3-hour lecture in of itself. And truthfully, I don't do any brain stuff, so some of that's leaving my brain as well. On the peripheral exam, simple things to start with are I like to kind of start from the snout and work my way back. So cervical range of motion and deep palpation, spinal palpation, tail jack, tail palpation. These are all going to let us know if there is any pain associated with a certain region of their body, which will be one of the first indicators of starting to hone in that neurolocalization. So now here's another question. What neurologic disease do you feel you see most in your practice? Again, similar to the question earlier, but kind of trying to hone it in a little bit. Are most of you seeing cranial nerve disease, seizures, peripheral spinal disease, such as down dogs, lower motor neuron disease, degenerative myelopathy, there's polyradicular neuropathies, or is there another type of neurologic disease that you guys are encountering more often? All right, get the results coming up. Looks like the most common, unfortunately, is seizures. That makes a lot of sense. I would agree that at point seized, probably the most common neurologic condition we see are pets that have seizures. Again, not really going to talk about seizures much or at all in this this PowerPoint. Second most common is going to be our peripheral spinal disease, down dogs, down dachshunds a lot. And then the rest of you guys are seeing lower motor neuron disease. So, all righty. So now we'll start talking about the focus on the peripheral neurologic exam. Again, starts the same with a nice distant exam. Is the pet walking? Are they ambulatory? Do they seem weak? Are they ataxic or a drunk, staggering type of gait? Are they scuffing their nails? Some other subtle things to look at. If you're able, when you're doing your neurologic exam, having a change in elevation is good to help pick up on those more subtle things. Do you have a curb in your parking lot if you're doing an exam outside? Do you have a little ramp in your building or something to that effect? But changes in elevation can sometimes reveal those more subtle signs. And as you can see in the picture here, this dog has scuffing clearly of the toenails there that if you weren't actually looking for, you could easily miss that kind of thing. Other terms to be familiar with that give us a ton of information when used correctly and allow us to be very concise when we get to the point of making a diagnosis. Paraparetic, that lets us know that an animal still has motor. They're not using their hind legs well, but they still can move their hind legs. And then you preface that with an ambulatory or a non-ambulatory paraparetic. That gives me a lot of information. When you say paraplegic, that gives me a lot of information as well. And you no longer even have to say ambulatory or non-ambulatory, because I know if they're paraplegic, they're not ambulatory. So, trying to be concise with some of these descriptions is really helpful. Hemiparetic, hemiplegic, again, that's one-sided. So if the right side affected or the left side affected, and then monoparetic, monoplegic, is there a single limb that is affected? And using this terminology and using it accurately and appropriately can allow you to communicate with a neurologist in a very concise way, especially if we do get to the point of considering a transfer for a workup. Here's a diagram we may all remember from vet school, and it comes down to where and when are we going to see neurologic signs the first with these peripheral diseases. And most often we think about compressive disease, so things like a disc herniation. So when we have something like a disc herniation or a tumor or even trauma, a hematoma, what part of the spinal cord is actually going to be affected first? And one of the first things that typically goes is proprioception. And we can see, I'm not sure if you can see my marker on the screen there, but these peripheral tracts, proprioception is one of the most peripheral things in the spinal cord. So it's going to be affected most, even with more subtle neurologic changes or more subtle disc herniations. So remembering the depth and the location of these specific tracts in the spinothalamic tracts, vestibulospinal tracts, etc., helps give us a more full understanding of why does this animal have proprioceptive deficits, but still has pain sensation, for example. And that's because those pain sensation tracts live deeper within the spinal canal. So now once we've done our cervical manipulation, thoracic manipulation, now we're going into our proprioceptive positioning. A lot of people like to use a misnomer of conscious versus unconscious proprioception, and the reality is it's extremely difficult to differentiate the two. So in general, just proprioceptive positioning, this dog has decreased proprioception is more appropriate than trying to distinguish that conscious versus unconscious. The way that we do that is typically we take a paw and we place it upside down as seen in the photo here. And most patients should rapidly return that to normal within a second or two. Sometimes, as you're giving them a little bit of support, they may not respond or they may not flip it over unless you shift a little bit of their weight to that limb. So when we're doing these tests, we're typically, offering some amount of support to that animal, and we're supporting them completely and flip their toe over. They may not, sense that both consciously or unconsciously. So we need to shift their weight to that limb a little bit to see if they actually have a deficit or not. So we do that a few times on each limb just to make sure there's not a single fluke, for example. Again, noting here that the proprioceptive tracts are the most peripheral in the spinal cord. So that's why these tests are one of the most sensitive in diagnosing if there is some amount of neurologic dysfunction for a patient. This will be one of the first things that changes. Other tests that we don't really do a whole lot because they're again, less necessary in a more realistic setting. But if you want to do a super thorough neurologic exam, or you're spending time with a neurologist, they would likely do a lot more of these guys. For me, the CP deficits, the proprioceptive deficits, just standing, are sufficient most of the time. But sometimes for fun, if it's a smaller dog or even a bigger dog, we'll do some hopping or some wheelbarrowing. And the placing is when you cover their eyes and bring their toes to the side of a table and see if they pick their foot up to place it on the table, such as this last picture here. Again, all of these are just giving us a sense of, does this animal have normal proprioception? Are they hopping their foot appropriately? Are they walking appropriately? Do they feel the table and put their paw appropriately? So all, again, just trying to see, is there any type of subtle deficits present? So once we've done our proprioceptive testing, next thing I like to move on to is our myotactic reflexes, i.e. you tap something and something else happens. It's very important to remember that that most of these reflexes, or all of these reflexes listed here, are spinal reflexes, meaning the information goes from the reflex hammer to the tendon to the spinal cord and then back to the muscles, meaning there's no actual brain involvement. So with these reflexes, it's really important to remember that just because they have an intact reflex does not mean that they actually have a connection all the way to their brain for that reflex to happen. The two most reliable reflexes are listed here: the withdrawal reflex in the thoracic and the pelvic limbs, and the patellar reflex. Some fun asides, just in case you didn't know, we have a picture of a reflex hammer here. The flat end is used for tendons, and the pointy end is used for muscle bellies. So if you're ever curious why there's a pointy bit and a flat bit, really you're supposed to use the flat bit on the tendons and the pointy bit on the muscle bellies. So we'll go through each of these briefly. After a second question, which the answer unfortunately looks to be highlighted there for you. Will a reflex hammer work on a ligament? And the answer is no. So no need to have that polling question going there. The reason is it's not attached to any Golgi tendon organs. There's no muscle attached. You remember, tendons attach bones to muscles, and ligaments attach bones to bones. So trying to tap a ligament isn't going to be very fruitful. Again, here, what nerve is responsible for the withdrawal in the thoracic limb? Again, trying to get into some of that long ago anatomy to see if you guys remember any of that, but there's the answer already for you: the musculocutaneous. Little less. And then where does the musculocutaneous nerve originate? C6 to T2. So the reason for all of these questions is really when we get to the point of, at the end of the PowerPoint, trying to hone in our neurologic diagnosis, we can really, with a really thorough neurologic exam, isolate where we believe the lesion to be in a very precise manner. We would never, take an animal to surgery without advanced imaging based off of our assumptions on the exam, but we can get very close to, identifying where a lesion may be in some cases. Moving forward with more information about the withdrawal reflex. So the withdrawal reflex, the musculocutaneous nerve in the thoracic limb, and the sciatic nerve in the pelvic limb. Essentially what we do is we pinch the toes, generally the webbing I pinch, hold on, and they should withdraw the limb all the way up to their body. And most dogs, even small dogs, are going to readily be able to snatch that leg away from you. So sometimes you got to hold on pretty good to make sure you elicit a full withdrawal. Typically doesn't require a ton of pressure. This is not a pain sensation test. So the withdrawal, just because a pet withdraws from you, does not mean that they have pain sensation. And that's a very common thing that I see, is that, folks say that they get a withdrawal and they think that means the animal has pain sensation. but that's not true. The withdrawal reflex is a spinal reflex. So just because they pull their foot away from you does not mean that they felt pain. So they have to give you some kind of stimulus or some kind of feedback that, hey, I felt that hurts. They should look at you, they should try to bite you, they should growl at you, try to get away, something to let us know that tract, actually the pain component of the spinal thalamic tract went all the way up the spinal cord and all the way to their brain and all the way back down, versus just a spinal reflex where it just goes to the spinal cord and back. The cutaneous trunci reflex is really helpful in these peripheral neuropathies. The lateral thoracic nerve comes from C8 to T2. The cutaneous trunci reflex, also sometimes called the panniculus. Again, this time we start at the wing of the ilium. When you're doing the cutaneous trunci reflex, starting at the wing of the ilium lets us know that if it's intact there, we're done. It's not necessary to track that cutaneous trunci forward, cranial, cranial. And then it's not really necessary to start cranial and then work your way backwards, because still at that point, you have to pinch them 5-10 times to finally realize that it's normal. So part of the neurologic exam is remembering how the neurologic system works, where things originate, where they end, and trying to be, efficient with your time, and also trying to be kind to the animal. Again, it's not really necessary for me to pinch that animal more than once if the cutaneous trunci is present all the way at the wing of the ilium. Now, if the cutaneous trunci is not present, then you work your way cranial. And interestingly, where the cutaneous trunci picks back up, if there is a lesion within the spinal cord, it's typically about 2 disc segments cranial to that lesion. And that has to do with the way the anatomy of the neurons actually track cranially for the cutaneous trunci before diving into the spinal cord through that dorsal root ganglion. So a little fun fact, as far as neurologic exams go, if you have a patient that you suspect has a brachial plexus injury and they do not have a cutaneous trunci reflex on that side, more or less gives you a slam dunk diagnosis that the brachial plexus is indeed injured, if not the complete brachial plexus, at least the caudal brachial plexus. And again, that's because the lateral thoracic nerve comes out from C8 to T2. So if you have a patient come in that's been hit by a car, they're dragging their front leg, they have no pain sensation, they can't move it at all, you're curious, is this a radial nerve injury or is this a brachial plexus injury? Then considering utilizing the cutaneous trunci as a marker, if it's present, then, start looking deeper. Is it possibly a radial nerve injury, or is it absent? That gives you a lot of ammunition to say this is probably a brachial plexus injury. So little fun fact about the lateral thoracic and cutaneous trunci. Now we're working towards the pelvic limb. The patellar reflex is technically the most reliable reflex out of all of these. Interestingly, it can be decreased to absent in older dogs, so you have to take that a little bit into effect when you're doing these guys. When you're doing your patellar reflex, remember you are tapping the patellar tendon, which is between the patella and the tibial tuberosity. Again, we're using that flat side of the hammer. The limb should be nice and relaxed. The patient is typically in lateral, supporting the leg and just letting them relax if they will. A nice gentle tap, and then you should see a nice knee-jerk reaction. This can often be done on the down limb. So sometimes when an animal is on their side, their downside is actually more relaxed than their upside. So you can often utilize this reflex in the pelvic limb as well, in the down limb to identify a normal or abnormal patellar reflex. Now remember, the patellar reflex is generally driven by the femoral nerve, which again comes out from L4 to L6. So again, thinking about neurolocalization, we can even differentiate the spinal segments L4 to L6 versus L7 to S1, L6 to S1, just by if there's a difference between the patellar reflex and the withdrawal reflex, may let us very, very much hone into where a lesion may be localized. And as I mentioned earlier, here's a little diagram as a reminder. We have the Golgi tendon organs that are in the actual tendon themselves. And then within the muscle bellies, we have the muscle spindle cells, those working in conjunction with the alpha motor neurons and gamma motor neurons, going up to the spinal cord through that dorsal root ganglion, being interpreted by the spinal cord as sending out that signal to do a little quick quadriceps contracture there. So again, all that isn't really all that important to put in the old memory bank, but just in case you were curious and were thinking back to all that anatomy, what was that called? There's a little bit of information on the Golgi tendon organ, etc. So this is the perineal reflex. I put this picture up here mainly for Mike Nystrom because a couple of things wrong with this picture. Number one, this gentleman is not wearing gloves, which I found kind of humorous. He's also pinching the perineum, which I find even more funny, being that he's not wearing gloves. But anyway, I don't know if Mike's logged in or not, but I hope he is to have nightmares about this picture. But the perineal reflex is looking at the pudendal nerves, which are one of the most caudal set of nerves, coming out from the sacrum, S1, 2, 3. So that again gives us some lesion localization if there were, a lack of anal tone in this region, or if there is no, perineal reflex, lets us know that this lesion, at least in part, is pretty far caudal. So bladder palpation, one of the most challenging part for neurologic patients, whether it's a disc herniation or traumatic luxation or anything really dealing with the neurologic system that may affect continence. So the bladder is really a game changer and often a stopping point for folks when it comes to, are they going to be able to take care of these pets long term? Because again, having a pet that's incontinent is extremely challenging, requires a lot of coaching, a lot of discussion, differentiating upper motor neuron versus lower motor neuron. An upper motor neuron is going to be upper motor neuron bladder is going to be pretty taut, very difficult to express. Ruling out an obstruction obviously is important there, but if it is neurologic disease such as a disc herniation, having that bladder that's really firm and taut because it has that upper motor neuron component. Lower motor neuron bladders are very flaccid. They're just kind of dribbling. They're not retaining urine. So, we're dealing with urine scald and just, diaper rash equivalent. So that's one of the big things that we do have to consider and talk about with our clients if their pet does have neurologic disease is bladder function. Will they have an upper motor neuron bladder? Will they have a lower motor neuron bladder? What it means, what medications to consider for treatment, how it's going to be managed, etc. So now on to pain sensation. So pain sensation is the most important consideration for prognosis in pets with spinal cord injuries. Now, there is a little bit of debate in literature about what it means for an animal to be deep pain negative and what it means for their prognosis. Historically, there's been, mostly older thought is that animals that are deep pain negative, especially if they're deep pain negative for more than 24 hours, have a much lower recovery rate than those that have intact pain sensation. Kind of older thoughts are, if they lose deep pain sensation, it's less than 20% prognosis. If they've been deep pain negative for over a day, then recovery chances are less than 5%. However, there are some more current studies that have shown with more optimism that these pets maybe even have upwards of a 50% chance of recovery, even if deep pain negative. There's also some new studies out there that talk about the 24-hour rule. A lot of people like to joke that a group of neurologists got together and put that study together so they could have a study that says, I don't have to come in tonight. It doesn't matter if it's within 24 hours or not, versus coming in with that deep pain negative pet at 11 o'clock at night. So, but nonetheless, there is a study that has shown that that 24-hour rule is not really as hard and fast as we once thought. So, but overall, as with a lot of things in veterinary medicine and veterinary literature, we have to
take the data set for what it is, and we have to make some of our own conclusions. And, the reality is, for these deep pain negative guys, I'll generally give them a 50-50 prognosis, because there is more recent studies that are showing that that's more likely the case. And again, when it comes to pain sensation, I can't stress enough how important it is to make sure that animal feels pain. And for an animal to know an animal feels pain requires that the animal shows you a conscious stimuli or response to what you're doing to them. So if you grab their toe and they just pull their leg away from you, again, that's a very normal withdrawal reflex. But if they're still just looking off in the distance when that's happening, perhaps they didn't actually feel it. So when you squeeze that toe, you squeeze that webbing, you pinch their tail, what have you, that animal needs to look at you and look at you repeatedly. That animal needs to, vocalize or whine or cry, or, needs to give you a sense that they truly felt and interpreted that pain, because that is going to be the most important prognostic indicator when it comes to, are they going to have a good outcome from surgery? And I didn't put it in the notes here, but if these animals do have pain sensation, their chances of recovery after, disc herniation, for example, are very high. 85 to 90% of these dogs will recover, even if they are plegic. If they're plegic, pain positive, they still have a very good chance, over 85% chance of recovering, ambulation. It may not be perfect, but that dog should be self-sufficient. At least 85% of them will. So again, very important to truly differentiate, pain sensation versus those spinal reflexes. Now, we talked about this a little bit earlier in the diagram of the spinal cord itself, but the order of loss of neurologic function first to last. And this is why, in part, deep pain is one of the most important prognostic indicators, is because those tracks do live deepest within the spinal cord. And I'm sorry, I forgot to mention on the last slide, unfortunately, when it comes to paraplegic, deep pain negative pets, Frenchies are the most likely to then move on and develop myelomalacia. So I know there's a lot of publicity around Frenchies in the literature, but if you do have a Frenchie that comes in that's paraplegic, deep pain negative, they do have the most likely, upwards of 15 to 20% of them will end up developing myelomalacia. So that's a conversation to be had with these owners that come in with these acutely paraparetic or paraplegic animals. So again, back to order of loss of neurologic function. The first thing is proprioception. We showed that those tracks are most peripheral. The next thing that goes is motor, followed by continence. Mostly we think about urinary continence here. Most animals with spinal disease will still have a relatively normal colic reflex, where once the colon gets filled enough, if they don't have any signals inhibiting them from going to the bathroom, they will expel the feces again. But urine is a tricky bit of business, especially with those upper motor neuron bladders. So after continence, we have superficial pain. So if you can pinch those toes and with your fingers, and they show you that reaction, versus they don't really show it when I pinch them with my fingers, but when I grab those hemostats, perhaps they then do show that deep pain. And it sounds pretty cruel, but you need to pinch them, and you need to try to hurt them, because again, it is the most important prognostic thing that we have. So pinching their toes and taking a hemostat and making the hemostat click in place is sometimes required to see if they truly do have that pain sensation. So again, once we have here, remembering the neurologic exam and remembering what you've gotten up to in terms of finally deciding whether you need to do a test for pain sensation. If an animal has motor, then they have pain sensation. So there's not any need to pinch an animal's toes that has motor. So you have a down dachshund come in, they're moving their hind legs, they can't walk, but they're moving them. There's no need to test that animal for pain sensation. Again, if they have motor, they have pain sensation. And just like the cutaneous trunci, if the cutaneous trunci is present at the ilium, no need to keep testing cranially So that's one of those things with neurologic exam, where keeping these facts in your mind can help expedite that overall exam and not doing unnecessary tests and creating unnecessary morbidity for the patients. So again, keeping this order of loss of neurologic function first to last is a handy little thing to think about as you're going through your neurologic exam. And then return to function is just the opposite. The first thing that comes back if they've lost everything is deep pain, then superficial pain, continence, motor, proprioception. So theoretically, if an animal comes in and they have motor, so they come in and they're plegic, they have surgery, they're decompressed, and then they regain motor function, most of those animals should theoretically have the ability to control their bladders as well. And remember, in this case, continence is referring to that urinary continence. So earlier we listed the triceps reflex, the extensor carpi radialis, tibial, etc. These reflexes are typically used with the pointy point of the hammer, but they're not reliable. They're not really validated. So, in general, I'm not going to waste my time with those parts of the neurologic exam. Of course, never wrong to do them and report them, but, the value of those is extremely limited. So keep that in mind as you decide to do those. So we've kind of gone through all the components of a pretty thorough peripheral neurologic exam. And so how does that relate to the PET, and how do we start working on our lesion localization? So remember, the spinal segments are C1 to 5, C6 to 2, T3, L3, L4, S1, and S1, 2, 3, depending on which textbook you're referencing. And ultimately, it comes down to what is happening behind or caudal to that lesion. Most of the time, what we lose are inhibitory signals. So in cases when we have a T3, L3 myelopathy, which is the most common that we reported that we see, what we're losing commonly caudal to that is inhibitory signals. So that's why when we have a T3, L3 lesion, the bladder, those inhibitory signals that allow those sphincters to relax are blocked. So those sphincters that control bladder control are very tight. And that's why it's difficult to express them. So going through this diagram here, upper motor neuron means that things are tight. They're really contracted. The neurons are constantly firing. Lower motor neuron is when things are more relaxed or absent or flaccid. So typically at the level of the lesion, especially at C6, T2, and L4, S1, 2, 3, that's when we're going to start having those flaccid type of responses where we don't have a withdrawal reflex, or we don't have a patellar reflex, or we don't have a sciatic reflex. Whereas the lesions with T3, L3, and C1 to C5, typically things caudal to that are going to be normal or exaggerated. Again, exaggerated because they do not have those inhibitory signals to tone them down. So a T3, L3, perhaps we do a patellar reflex and there's nothing inhibiting that reflex. So we tap the tendon and they kick 2 or 3 times, so they have some spasticity. Or we tap the reflex and it's really exaggerated. Or we tap the reflex and it's pretty normal. All those are to be expected and are within the realm of a T3, L3 myelopathy. So lesion localization is all about, honing in on where your lesion is, knowing what to expect in front of the lesion and behind the lesion. So typically everything cranial to a lesion is going to be normal. We have that T3, L3 myelopathy. They're going to have no pain in their neck. They're going to have normal withdrawal. If you wanted to do the extra, extensor carpi radialis or triceps, all that's going to be normal. We're going to do our cutaneous trunci, but then it's all of a sudden going to cut off. And typically, again, it's going to cut off 2 disc bases caudal to the lesion. So for example, if we have a disc herniation at T13, L1, our cutaneous trunci is typically going to cut off at around L2. Once we get to L2, the cutaneous trunci stops. The lesion is typically going to be 2 segments cranial to that. So T13, L1. And then everything caudal to that lesion is going to be, again, either normal, such as the patellar reflex and the withdrawal reflex, or maybe exaggerated. Now, when we get into the, the cervical and the pelvic intumescences, the C6, T2, and L4S1, when we have those lesions there, that's when we're going to start seeing the loss of those reflexes, because, again, as you remember, in the thoracic limb, withdrawal is the musculocutaneous. That comes from C6 to T2, which is the exact same spinal segments as that C6, T2 lesion. So if that lesion is damaged, then those nerves aren't going to function correctly. Same thing in the pelvic limb with L4 to S1, S2, S3. We can even further localize that lesion if they do have, for example, an intact femoral, but they have a decreased sciatic. Then we know that lesion is probably more caudal, L6, 7S1 for sciatic, L4, 5, 6 for femoral. But again, if they have a normal with femoral and a decreased sciatic, that just, again, allows us to further localize that lesion. And then the pudendals back there very caudally with that perineal reflex. So again, we could spend an entire hour on localizing the lesion, utilizing this chart. But again, hopefully as a little refresher, that makes a lot of sense to most of y'all. And again, if y'all have any further questions, I'm happy to chat independently or a little bit later about any of that. So lesion localization, I had these questions up here, but unfortunately it looks like they're also giving us the answers a little earlier than I wanted them to. So we have a 4-year-old neutered male dachshund that is acutely paraplegic. So that gives me, again, a ton of information, just by simply saying that they're acutely paraplegic. That lets me know that they do not have motor. It doesn't tell me anything about pain sensation. It lets me know that they're non-ambulatory. So, we go through our physical exam, we identify that the cranial nerves are within normal limits, the thoracic limbs are within normal limits, the cutaneous trunci cutoff is about L2 to L3, the patellar and withdrawal reflexes are normal. This animal does have deep pain. So this is a very classic case of a dachshund coming in with a T3, L3 myelopathy. So our lesion localization, again, is T3 to L3. Which, again, I apologize. I was hoping to have you guys answer these questions, but I think they got lost in the shuffle. So we'll go through again. I have a few of these cases. Lesion localization, 4-year-old neutered male dachshund, acutely tetraparetic. Tetraparetic, so all 4 limbs are affected. The animal is weak. The animal still has motor in all 4 limbs. So that one sentence gives me a lot of information. Moving forward with the cranial nerve exam is within normal limits. Our thoracic limb reflexes are within normal limits. So that lets me start narrowing down that lesion localization. Cutaneous trunci is within normal limits. The pelvic limb reflexes are within normal limits. So we just have an animal that is tetraparetic, but all the spinal reflexes seem to be intact. So that lets me know that this lesion is a C1 to C5 lesion. All right. A little side note about C1 to C5 lesions. It's very common that pets with C1 to C5 lesions may have a decreased withdrawal in that thoracic limb for unknown reasons. We don't know why it is. At least I don't know at this point. So it is very common that even when we do cervical spinal surgery, our lesion localization may be C6 to T2, but it turns out, with advanced imaging, their lesion localization is C3 to 4, for example. Another big note about C1 to C5 lesions is these animals can sometimes acutely decompensate because of respiratory dysfunction. And this has a multifactorial level where part of the phrenic nerve travels through very closely to that part of the spine, as well as the signaling from the reticular activating system and the brainstem also courses very closely to that C1 to C5 segment of the spinal canal. So one thing we do have to warn these clients about, if they have a pet that comes in that has a C3, 4 disc herniation, most often it's more cranial than that. The C2-3s are the most common, but we do have to warn them of a acute risk of respiratory decompensation because of these important respiratory drives that pass through that region. Next case was a 6-year-old spayed female beagle that is acutely paraplegic. Again, a lot of information there. I know the pet cannot move the hind limbs. Cranial nerves are normal. The thoracic limbs are normal. Cutaneous trunci cutoff is normal. The patellar and the withdrawal reflexes are absent. So the key difference there between the other one is that the patellar and withdrawal reflexes are absent, and deep pain is also absent. So in this animal, because those withdrawals and patellar reflexes are absent, we'll localize them to L4 to S2. And then finally, as we work through our trip here, 5-year-old Shih Tzu presents for being acutely tetraplegic. So now we have a patient that isn't able to walk or move any of their limbs. The cranial nerves are within normal limits. The thoracic limb has absent reflexes. Cutaneous trunci is normal. Patellar withdrawal is normal. Pain sensation is present. So again, the difference here being that their withdrawal reflex in the thoracic limb is absent. So that brings us to that lesion localization of C6 to T2. Some key points about the neurologic exam is that the neurologic system is extremely complex, but it's extremely predictable. So once we are able to develop a very nice grasp of the neurologic system, especially neurolocalization, we can really readily and rapidly, localize a lesion and be pretty accurate. Like I said, at some points, we get the cutaneous trunci very accurate, and we can guess that, when we do our imaging, we're going to have a L1-2 lesion and be very, very close. So with, a good neurologic exam and practice and recalling all these neurologic features and traits and expectations is, a really helpful way to help these animals with neurologic dysfunction. It's important to, repeat neurologic exams as needed, and to keep in mind that pain sensation and true pain sensation is one of the most important factors of prognosis for these guys. Again, even a paraplegic animal with pain sensation has an 85–90% chance of recovery. Again, I tell folks that they may never be perfectly normal again, but they should be self-sufficient, fully ambulatory. They may always have a hitch in their giddy up, but it's better than being in the ground. There's actually a ton of overlap within the nervous system, especially our peripheral nerves that we think about. We keep things simple because we have to, in terms of, the femoral nerve is L4, 5, 6. But this is a diagram of, the cervical nerves and the brachial plexus there. And I'm not going to go into it in any type of detail, but as you can see, you pick any nerve peripherally in that brachial plexus, and we can actually go a bunch of different ways to actually finally get to the spinal cord. And there have been studies that have shown quite a bit of variability in the brachial plexus. But again, knowing what to expect from various tests does give us a whole lot of information. A common thing that we sometimes see is Schiff-Sherrington. I wanted to share this again with you guys, especially those of you that work ER from time to time. Schiff-Sherrington is a paracute lesion that disrupts what's called the ascending border cells, which again are inhibitory cells that track cranially and inhibit the thoracic limbs from around that L1 to L4 lesion. So animals that have spinal trauma may come in with the Schiff-Sherrington complex, where they have their thoracic limbs, in extension. What we have to differentiate is, an upper motor neuron versus Schiff-Sherrington for these cervical lesions. And a really important thing to remember is that Schiff-Sherrington is not a prognostic indicator. So just because an animal comes in and Schiff-Sherrington posture does not mean that they have a greater risk of failed outcome than a patient that doesn't. It just has to do with that lesion localization being somewhere between L1 to L4 and how it's affecting those border cells tracking cranially that again play an inhibitory role in the thoracic limb extension. So if you see an animal with Schiff-Sherrington, It is not, a death sentence. It is not a negative prognostic indicator. And most often, with some basic supportive care, that will resolve. So, spinal fractures and disc herniations. Disc herniations, mainly we think about the Hansen types. These are, something that I did extremely commonly in Memphis. The most common procedure I did in Memphis during residency was TPLO, as you can imagine. The second most common was hemilaminectomy. So I'm incredibly excited to, when we move into the new building and we have our CT machine to offer this service to the state, the eastern part of the state, and get back to doing these procedures, which I find extremely fascinating, and I really do thoroughly enjoy spinal surgery, both disc herniations and traumatic luxations and fracture repair of the spinal canal. So these Hansen type herniations, you may have heard type 1, type 2, type 3 disc. There's some changing literature names. People like to change names of stuff. Kind of like HGE is not HGE anymore. It's acute. I don't know, don't get me lying. Anyway, Hansen type 1 is an acute disc extrusion or rupture. Hansen type 2 is kind of a chronic bulge over time. And then Hansen type 3 is an acute trauma with no active compression. Another term that has come across is high velocity, low volume. And then kind of the most current literature is acute non-compressive nucleus pulposus extrusion. I argue it's a whole lot easier just to say type 3, but the neurologist would probably disagree and find some flaw in that statement. So remembering those disc type herniations that you may come across. These are some images of a CT myelogram from Memphis that I did. So what we do with a CT machine, when it comes to surgical disease, a CT is very much just as good as an MRI in general for surgical disease. Now, if we were looking at an animal with seizures, or we're looking at an animal that we think has a meningoencephalitis, MRI is far superior imaging modalities. But for surgical disease processes such as disc herniations, spinal luxation, spinal fracture, a CT is, just as good, if not superior, in some situations, such as spinal fracture, in identifying those lesions. So on the left, we can see a very nice image of a normal part of the spinal canal. This is a CT with myelogram. So we'll put some dye in the subarachnoid space. So it really highlights that spinal cord beautifully there. And then the image on the right, we can see that it's not as pretty. There's not a nice, lovely circle there. So we can see that, that's where our disc herniation has occurred. And since it is a 3D reconstruction imaging, we can look at different planes to identify, is it right-sided, left-sided, L1, L2, L3, T13, etc., to let us know exactly where we're going to need to open up the spinal canal to find that disc herniation. And here it is for this little pup. So what we did in Memphis, which was pretty cool, was we would take IDEX bags and steam sterilize them. And then if we had anything interested we wanted to take pictures of, we could open them sterilely, drop your iPhone right in there and close it off, and your iPhone would still work with the bag and the glove on your hand. So I was able to get some pretty cool pictures of some surgery in a very nice sterile way. So this is an example of a disc herniation, after making that window. So as you can imagine, one of the benefits of hemilaminectomies are they're very rewarding, kind of like pressure washing. When you're done with the surgery, it's beautiful and lovely, and you feel like you did a really good job. So in summary, paraparetic and paraplegic dogs commonly seen in general practice and ER. A rapid neurologic exam before opioids or other dissociatives. Again, you want to make sure that you at least do that cranial nerve exam and, looking for central brain disease before altering their mental status. Very few words are needed to give a neurologist all the information they need. For example, calling over to NC State, or maybe calling over to me at the end of the year next year. Hey, I got a 4-year-old female spayed dachshund that's a non-ambulatory paraparetic T3L3 myelopathy. that gives me pretty much all the information that I need to have a good idea of what to tell you about that patient. Or another example, 4-year-old spayed female dachshund, tetraplegic, deep pain negative, C1, C5 myelopathy. Again, in the first sentence, you told me they were paraparetic, so I know that they have motor, so I know that they have pain. So you don't need to waste your time and breath saying that. So really, with this kind of talk and a good, accurate neurologic assessment, and really honing in the important parts of the description, really in a sentence or less, you can give, the neurologist or a surgeon that does neurosurgery pretty much all the information that they need to give you all the information that you may need to relay to the owner to help them make a very well-informed, guided decision. So that is my brief overview of, peripheral nerve disease and, how I approach the neurologic exam on these patients. I know it's a whole ton of information, and we could spend an hour on pretty much any one of those slides in the reality and go a whole lot more in depth into a lot of things. But in general, if we are able to, localize a lesion, then we can get the rest of the information that we need from our comrades, over at other tertiary facilities. Whether it be, if you think it's a central lesion, definitely don't send it to me. I don't do anything with the brain or anything like that. But again, hopefully come the end of the year, if you do have those, surgical decompressive dogs, we really hope to be offering that service by that point. And I really look forward to offering that to the community as well. So we have about plenty of time for some questions this evening. So we'll open it up to Paige.
Yeah, Dr. Brady, thank you so much. And thank you for always putting these more complicated topics into what I consider easier to understand ways. I always really, really appreciate that. One of the questions I had while listening was, which I never really gotten a really straightforward answer to, because everyone might have a different answer, but if I'm thinking about referring one of these guys to you, and your team says, yes, we can take it, when is the last appropriate time to give any sort of opioids? And do you want NSAIDs? Do you want steroids? What are your opinions? Or just leave it completely alone and send it and let the team there decide what it gets next?
Yeah, so I have the reality is, if you're sending me a down dog, I know that I'm not really too worried about central disease or cranial disease. So you can give that patient, any opioids at any time to help them be more comfortable, because, unless on your assessment you notice something weird on that cranial nerve exam, we know that there's a 99% chance that this down dachshund you're sending me is a disc herniation, right? So for the pain control from the opioids, from that example, for me, use them indiscriminately once you've been able to rule out cranial disease yourself. As far as steroids versus NSAIDs, I lean towards NSAIDs, and the reason for that, if the person is readily able or wanting to consider surgical correction, I reach for NSAIDs. And the reason for that is there's a couple of studies that don't explain it, but they actually show higher survival rates in animals that are treated preoperatively with NSAIDs before decompressive surgery than with steroids for decompressive surgery. So in that case, in general, if they're interested in referral, I have no qualms with an NSAID being on board for that patient, or just give them some opioids and send them over, and then we can make some assessments from there. With pets that say, hey, I can't afford surgery, or I'm not interested in surgery, then I typically will reach for higher doses of steroids. And the reason for that is, I believe, and there's some studies that show a little bit of improvement from that, but kind of a lot of the current neurologists will strongly disagree with high dose steroids for these guys and say there's no literature backing and stuff. But at this point, for an animal, I believe that their best chance, if they're not going to be able to go forward with surgical decompression, that they're going to have the best chance with a higher dose of steroid. I have utilized that 30 mg per kg of methylprednisolone injection, followed by 12 hours later a 12 mg per kg methylprednisolone injection that's been described in the past. Again, in that case, it's a Hail Mary. So as long as the owner is aware that it's a Hail Mary, I'm very comfortable, trying something like that in an effort to maybe preserve a pet's life. So for those pets that do not or are not interested in surgery, I'll typically reach for higher doses of pred, the higher end of the anti-inflammatory dose, 1.5 to 2 mg per kg, pred equivalents. For pets that are going to move forward with surgery, they have shown greater survival with the NSAIDs. But in general, if you're able to get them on some good opioids and stuff, we can go from there with what we're going to do post-op steroids or NSAIDs. Because sometimes there's a ton of inflammation in surgery. I'll then again reach for a steroid versus an NSAID.
Thank you. Question here is, how can urinary continence change with time?
Yeah, so in general, it will improve over time. If you're talking about upper motor neuron bladder, I guess I need a little bit more information to accurately answer your question. Are we talking about a dog with spinal disease, upper motor neuron bladder after disc herniation, or are we just talking about a lower motor neuron bladder? I need a little bit more information, I think.
Yeah, I don't have that clarified here, but maybe this person will chime in. But I think we all have experienced the dachshund that's your weight, maybe it's even had surgery or it's under medical management. How about that one?
Yeah, so those pets typically they will become easier to express over time. I believe it comes down to muscle fatigue. There's not a good working theory out there that I'm aware of for that, but in some of these cases, I do feel like after several days that those, whether it's just muscle relaxation or decreased acetylcholine available at the neuromuscular junction, but I do feel like that even over time in pets that are neurologically static, they do become easier to express over time without medical intervention. I typically will reach for acepromazine above other medications like prazosin in those pets that I feel like have a little bit of difficulty expressing. Kind of acepromazine followed by diazepam followed by prazosin.
Gotcha. Thank you. Does anybody else have any questions? Dr. Brady, someone asked while you were talking about whether or not your PowerPoint would be able to be shared, and I said yes, that we would send it with the CE certificate. Obviously, this is some really good information that would be really nice to have as a reference point.
Yes, that's absolutely fine.
Right. I think we might be, let's see, there might be something else coming through. One here says, I've seen companies offer, quote, disc health supplements for sale using glucosamine and such. What do you think about those?
I don't buy into any of that. They've actually done studies in dachshunds to see if there are preventative measures for disc herniation, and the reality is what they found is that there's not. They even, they very commonly tell folks to get their dachshund lean, but they've actually shown that there's no correlation with body condition score and disc herniation risk in dachshunds. I still recommend you tell people that because it may be a little bit more motivating for them to keep their pet at a good body condition. But the reality is that there's, to date, there's not even there's no known preventative measures, including things that we would think would be really helpful, like decreased activity, decreased jumping off of couches, better body condition scoring. None of those things actually have been proven to be risk factors for
increasing or decreasing the risk of intervertebral disc disease. So in the whole glucosamine and disc health thing, I believe it is very much the same as, you know, peripheral joints. There's a lot of folks out there with a lot of, you know, information on various joint supplements, et cetera, because that's all it is. You know, a joint between every vertebrae. You know, that disc in the back is, you know, not a whole lot different than a meniscus in a knee, except for there's a little jelly in the inside. So there's been no proven clinical data that I'm aware of that have shown true benefit in joint health associated with any of the joint supplements that we have available.
Gotcha. Thank you.
A lot of anecdotal stuff out there. Folks anecdotally say they start a joint chew and it helps their pet, or Adequan, it helps their pet, etc. But there's no controlled prospective studies that I'm aware of that show, you know, improved ground reaction forces, etc.
Another question here, and I don't think you mind, I just don't know which one to provide. Is there an email that is possibly available to discuss a case challenge? Would you want that to be your Robert Brady or the hospitals?
Yeah, Robert Brady is fine.
Okay. I will type that in so everyone can get it.
It doesn't get lost in the shuffle.
Yep. Just making sure I'm not missing anything. So there's a good handful of people here that are direct referrals to Points East. And so when Dr. Brady's talking about the new building, we're have a new building that will open in October with a CT and the ability to cut these cases, which I know personally, a lot of times I can't get people to go to Raleigh, but I can get them to approve surgery. So having somebody more local that can do it is going to be a good, big game changer for a lot of our patients. So thank you, Dr. Brady, for being open to these cases.
Yeah, absolutely. And then it was like the same person had a follow-up question about if that opinion changes after surgery or conservative management, not prevention, but more for comfort and pain management. It's one of those things that I'm of the theory of it might help, but definitely shouldn't hurt. You know, if we feel that our pets or patient are, you know, more comfortable with a joint supplement, then I'm 100% for it. I don't typically get into multiple layers of supplements. So for example, I don't recommend feeding a veterinary joint mobility diet, as well as giving them a joint supplement like Dasequin. Double dipping, so to say, in that fashion is really just a waste of finances, because as with pretty much all supplements, what our body doesn't use, we just excrete. So for those cases, you know, I would say do a Dasequin advanced, or do a joint mobility diet, but not both. So I don't have a lot of personal experience with the medical management side, because typically most of the time, by the time they come to me, they're ready for and expecting surgery. But I very much do prescribe to, there are a lot of things that shouldn't hurt, but might help.
I believe I put your email in the chat, but then I moved in the Q&A. I can't really see. I put it in both places. I just don't know if somebody can't see it, it will be included when we respond with your CE certificates as well.